normal webinars. We've got another really good one for you guys tonight. We're going to be talking about geriatric and just in general osteoporotic ankle fractures, and if there are things that we need to do differently than we would for younger people. So my name is Jennifer Hagan. I'm Associate Professor of Orthopedics here at University of Florida, and I am joined tonight by two awesome surgeons whom I both personally know. Dr. Krupko, he's an assistant professor down here at the University of Florida as well, and Dr. Brian Weatherford, who's a clinical assistant professor at the University of Illinois in Chicago. So welcome to both of you guys. Thank you for joining us tonight. These are our disclosures. Dr. Weatherford is the only one who makes any money. As with all of these, AO North America is an independent nonprofit surgical specialty. We do not endorse or promote the use of any of the product or services of commercial entities. So patients with osteoporosis, and I would just include other poor host factors, and that can be a variety of things that we'll talk about tonight. So advanced age, poorly controlled diabetes, extremes of weight, both grossly underweight and grossly overweight, often cannot be managed with traditional osseous fixation because of their higher failure rate. And this is already a conversation that we have in, say, geriatric hip fractures or older people with distal femur fractures, in that we might change some of our tactics to accommodate the poor bone and perhaps accommodate them weight bearing earlier. It's not something we really talk about too frequently around the ankle, but it might be something that we do need to talk about. So the goal of this webinar is to discuss other methods besides the traditional methods that we all know for fixing the ankle fracture. Again, our learning objectives is to have a better idea of the patients who might be at risk for having poor bone quality or impaired soft tissue healing, and really just describe ways of changing your fixation or your approaches to patients who do have poor bone quality. And then we'll talk a little bit more also about postoperative protocols, which we don't always talk about in webinars. You know, how soon do we actually get these people walking, and do we change anything about our mobilization for these patients? So this is our agenda. We're going to try to get through at least 4 cases. I know both of our speakers have multiple really interesting cases they want to share, but we'll try and get through 4 good ones for you guys tonight. So what is the problem? So this is the 3rd most common fracture seen in patients over 65 years of age, right? It doesn't have the same mortality cost to it as it does with the hip fracture, but it's more than just weak bone. And this is one of the things I found interesting as I started to delve into this, is that osteoporotic fractures and geriatric fractures of the ankle aren't always the same. They're not synonymous. And there actually was a study that showed that the average bone mineral density on geriatric ankle fractures was higher than that of the patients that had hip fractures. So it's not necessarily just that they have weaker bone. It's also a combination of the fact that they overall might be more obese and also have balance issues. And I think any of us on this webinar that have taken care of 40, 50, and 60-year-olds that might be more really obese, and we've seen them fall into their own body weight, and sometimes have horrific open ankle fractures from what would otherwise be a ground level fall. So that's the population that we're going to be talking about tonight. This was a quick meta-analysis. This is not the first time people have thought about this, right? This is just a quick meta-analysis of all the different papers that are out there that have discussed ways of augmenting fixation. Several of these techniques are going to be brought up in the cases tonight, but they include things like intramedullary fixation of the tibial-calcaneal joint, intramedullary fixation of the fibula, and also augmenting the screw holes. This is one interesting article that I hadn't seen before preparing this webinar that showed augmenting the screw holes with PMMA cement. This was in geriatric ankle fractures, and they also put in intramedullary K-wire, nothing larger diameter than that, and they allowed their patients to walk at 2 weeks, which I thought was pretty interesting. And then this was a biomechanics paper looking at augmentation of the screw holes, not using cement, but in this case they were using calcium sulfate and calcium phosphate, and comparing it to the tibia profibula screws. So the screws that go through the fibula and into the tibia, not necessarily because they have a syndagmatic injury, but just to augment the fixation. And they actually showed in this study that putting the screws in the tibia was equivalent. You didn't necessarily need to use the augmentation. So those were just 2 studies I thought were kind of interesting to kind of start off the discussion. And with that, we are going to start in our cases.
Perfect. Okay, so like Dr. Higgins said, I'm Tom Krupko. I'm an assistant professor here at the University of Florida. In my first case, my disclaimer before I start into any of this is that I, just so you guys understand my practice in general, is that I fix most of these. So the fusion is a relative rarity. And I'm trying to figure out still in my practice who should be fused and who shouldn't. And I think that's going to bear itself out in some of the presentations. And then again, we all do, I think. So 67-year-old female who fell yesterday, right? So we have our initial injuries here. You can see every blood vessel that goes down into her leg. You can also see that she has a trimalleolar fracture dislocation. Skin here, a closed fracture, but some significant soft tissue injury, a lot of swelling, ecchymotic skin. The blood all there is from a hematoma or a ankle block to do a reduction, but generally not the greatest looking soft tissues. Very, very sick lady. Chronic kidney disease, she is like just barely, she's got like one nephron left that's functioning. She's not on hemodialysis yet, but she's on her way. Maybe a question of early Alzheimer's. She's got a little bit of confusion, but generally is talking to ANO times 3, able to consent for herself, answer questions. She's got diabetes with a significant A1C and significant peripheral neuropathy, morbid obesity, COPD. She is not exactly one of my healthy players. Just because of soft tissues, placed her into an external fixator, and she really behaved like more like a bimal than a trimal, not a ton of anterior posterior instability. And then you can see our post-reduction CT scan. Now, at this point, as I'm kind of going through my own algorithm in my head, this doesn't look all that bad, right? I have a decent sized posterior mal, but it's minimally displaced in the X-fix. The medial and lateral mals don't look terribly complicated. And for me at this time, it was I like to avoid posterior approaches, right? So I thought I could avoid a posterior approach with this. It generally felt more stable when I put it in a frame. And so I was leaning towards doing fixation, and that's exactly what I did. I think it took her about somewhere around 7 to 10 days to be ready for this from a soft tissue standpoint. Made a lateral approach. I really cheat my lateral approach on the posterior border of the fibula, but not a true posterior lateral approach. Put a locking fibula plate on after a lag screw, 2 bicortical solid 3/5 screws in the medial mal. Something I do more readily in some of the folks who don't have good bone is place multiple bicortical screws to the medial mal. And then did a perk A to P screw through that posterior mal. That's a little bit of a different technique, something that I didn't always used to do, but start the wire and go anterior to posterior with the application of the wire, and then push the wire out of the skin posteriorly. And just as long as it's exiting really lateral to the Achilles tendon, that's a pretty safe area, right? And so we'll lift the foot, drive the wire out the back of the ankle in the appropriate trajectory to be safe with the neurovascular bundle, make a little nick with an 11 blade and put the screw P to A to hopefully get a little bit of a better compressive force on that fracture because of the head of the screw. Initially did fine. I was pretty happy with my reduction overall. The 2 syndesmotic screws also giving her some added fixation. And this is where I start to cringe a little bit now retrospectively, is the plan was non-weight bearing rather for 3 months because of her neuropathy, and walking boot once her stitches came out at 3 weeks to allow for range of motion. Here she is at about 2 weeks. Not great. She's in absolute maximum plantar flexion and some of that stiffness, right? She dorsiflexes out of that some, but even splinted, she started to develop some equinus. 5 weeks post-op, so we took stitches out of 3 weeks. 5 weeks, she was admitted to the hospital, to an outside hospital for urosepsis. She came to my clinic at 6 weeks, and this is what she looked like. Both of those tiny little wounds distally tracked down to her plate laterally. And so now we're having a long conversation, and I'm trying to salvage this and get her out to the 3-month mark at least before we're talking about removal of hardware. So we're doing dressing changes. Yeah, go ahead.
Oh, just real quick, Tom, I want to interrupt you before you get to the next thing. I thought that technique of the wire, the A to P wire with the P to A screw was interesting, right? Obviously, because we know the mechanics of having the screw on the screw head on the small fragment, is something that we've always thought to be a positive thing. I was interested, you said that you avoid the posterior lateral approach with questionable skin. Have you had problems with that?
I have. This has been a sticking point before. So for me, the two approaches I tend to avoid if I can are the posterior medial approach to the knee and the posterior lateral approach to the ankle. I've had people dehiss that wound. I personally have worse luck in the posterior lateral ankle in bad diabetics with folks with bad skin than I do with just doing a lateral approach and cheating it posterior. So I tend to do that. And I think you tend to do the opposite, right?
Yeah, no, that's curious because I to my recollection, it's always lauded that the posterior lateral approach is a little more forgiving because of there's more muscle back there. Brian, do you have the same feeling on that?
Well, I think you're both wrong, actually. So the posterior medial approach. So no, but I actually, so all kidding aside, my thought, I think of the posterior lateral approach as more forgiving. In terms of the soft tissue coverage versus being, right over a subcutaneous bone. But I believe it. I mean, if you've had bad luck with an incision, I mean, there's something to that, to doing something differently. I actually do, if I'm going to go after a posterior tibial articular piece, it's a case-by-case basis. I'm actually doing a lot more posterior medial approaches now. But that's maybe a separate conversation.
Interesting. Okay, cool. Yeah, I just wanted to highlight that because you mentioned it. I don't know if everybody picked up on the fact that you had problems. You've had problems with that approach, and again, it's usually one that, and I do tend to use it, and I push the limits on it for sure. Like I will do that approach in someone that has questionable skin more readily than I would a normal approach to the fibula. And I don't know, maybe I'm wrong. I mean, that's interesting that you've had some issues with it. So.
Well, I'll tell you too, I've made an effort now, both of those approaches that I mentioned, I make a pretty significant effort to close fascia. Now that we didn't do so much in training, and I didn't really do in my first couple of them that I did. It's not necessarily always doable. It's not always easy to do, but I think that eats up a lot of that dead space. Closing the fascia down gets rid of just a ton of that. And then if you have a dehiscence, I've had a few of those now where I'm staring at fascia, not down to the posterior ankle joint and the plate. And so I've had better luck, definitely since I've closed fascia, but it's just my own bias.
There is an anonymous attendee in the chat that said it has to do with the deep dissection. Obviously, making skin flaps is bad, and you're right. There is more of a skin flap with that approach, and they suggested incising through the perineal sheath, which I will do only if I'm also plating the fibula through that same approach. But it sounds like you might not be the only one having problems with it.
Yeah, no, that's actually my go. I go through the basically the way I do it is I go through the perineals on the back side, so through the posterior aspect of the lateral compartment fascia, and then roll that over, and then go down onto the fibula and then onto the deep posterior compartment through that. I don't know how much of a difference that makes, but that just to me makes more sense. I mean, because that's kind of one continuous plane going from the posterior aspect of the lateral compartment fascia to the deep posterior compartment. That's all coming right off the back of the ridge of the fibula.
Yeah. Interesting. Okay.
So that guy's right.
It's gonna be like that. All right. Okay. I'm sorry to interrupt. Keep going, Dr. Kropko.
Yeah. Okay. Well, we were done with the big parts of this one. So, okay. The goal was to get her out to at least 3 months before having to do a hardware removal. The goal was to have her have some kind of bony healing and not be dealing with an infected non-union, be dealing with an infection in bone that's going to fight back a little bit. Here she was at around that 3-month mark. She was not doing well as a whole person, but I let her walk. And she was able to bear weight. We were still doing some dressing changes to this area for now. But again, that lateral side specifically there's metal there, right? So we didn't quite do too well after this. So at 4 months, she was transitioned to hemodialysis and it was admitted to the hospital with some increased drainage and cellulitis, right? And so at that point, we made our incisions at 4 months, removed medial lateral hardware. It was not, the lag screw was not exposed, and I did not want to do the soft tissue dissection over the front to really get it out of there. I didn't think it was really involved. And again, she was looking so poorly, so poor from a general medical condition that it was just trying to get the plate out, wash her out, close her skin. At 5 months, She was admitted again for urosepsis and CHF, and she coded in hemodialysis and expired. And so for this one, looking back in time, by fusion, doing a hindfoot nail for her might have been the better way to go. I could have let her walk much, much sooner, and maybe avoided this outcome. She was a pretty sick lady, but I didn't do her a whole lot of favors keeping her off her ankle for 3 months. And so now some of this gets factored in when I'm making these decisions. One of those is, if I'm going to keep you off for 3 months, and you look kind of like this lady did, I'm leaning more towards a hindfoot nail that I can let you walk on at least right away and mobilize you.
Yeah, no, I agree. That's a tragic end to an ankle fracture case. There was a question in the chat box that given the minimal displacement of the fractures or the fragments in the X-fix, would you consider just treating her definitively in the X-fix? Do you ever have a role for that, either of you?
I'll weigh in on my, so not really for me. I mean, there's, I would never say never, right? So, I mean, there's certainly patients where I've done that. But I think that doesn't really do you any favors. It's difficult to control rotational ankle fractures with an external fixator. It's much easier to control kind of axial displacement or shortening with it than it is to control rotation. And then you've kind of got the worst of all worlds, right? You've got not the most robust fixation. You've got open pin sites, and really, again, mainly rotatory instability. So yeah, I mean, I think that, you know, for me, you have got to consider the patient as a whole, not just the fracture. So you either got to fix it and get them moving, or fuse it and get them walking.
Yeah, I would agree with that. I don't think if I leave an X-fix, it's usually to augment something else I've done where I didn't get to do what I wanted to do, right? So if I do perc fixation of the fibula and the medial mal because of the soft tissues are so bad, and I don't really trust my fixation, I'll leave the X-fix on to supplement, but usually do something else in addition to that to try to get tighter control. And then again, I think, even if I had left her in an X-fix, I would have not let her walk for that full 3 months, regardless. And then you can run into more problems there too, right? And so maybe if I was going to do that using HA-coated pins, or it's just, I don't know that I've bought myself too awful much by just going with an X-fix and avoiding extra fixation. I think a better idea would be if maybe just perk it and leave the X-fix, and I've done that a few times as well.
Yeah, I have a partner who no longer here that he treated a lot of ankle fractures definitively in X-fixes, and they all fall apart as soon as the frame comes off, right? Because it's always the patient that's going to be slow to heal, and then you take it off and you just see him slowly melt over time. So,
right.
All right, awesome. Dr. Weatherford, you want to share us your first one?
I would love to.
Oh, sorry.
Yeah, get out of here.
So stop sharing.
Yeah.
I'm oversharing.
All right. Can everyone see okay here?
Yep.
Yes.
Okay. All right. So I'm going to go backwards here. So as Jen stated, I'm Brian Weatherford. I'm from Chicago. I'm part of the Illinois Bone and Joint Institute and a clinical assistant professor with UIC. Despite my many conflicts, I have no disclosures relevant to this presentation. So my first case is an 89-year-old who fell off of a ladder while in her driveway trimming her hedges. And she lives independently with her boyfriend. She walks without any assistive devices and maybe takes less medications than I do. So this is her on presentation though. So this is a higher energy geriatric ankle fracture. So, you know, it's a, you know, kind of a pronation abduction pattern on steroids with the classic medial transverse tension type open wound, you know, that's roughly 180 around the ankle there. So I don't have a picture of it, unfortunately, but I think most of us have seen that. The wound just above the medial malleolar fracture with most of the plafond sticking out of it. And these are her CT scans, which I think the interesting things, you know, her fibula is just a touch comminuted. Again, just speaking to the higher energy nature, you can see some little soft tissue gas, you know, up along the tibia to the upper extent of that CT. And then the axial section is just to show, in case you were wondering if she has syndesmotic instability, she's got a touch of it. Yeah. So one of my questions, for you guys is, what this 89-year-old lady, still healthy, but 89, comes in with this, let's say medium energy open ankle fracture. What's your go-to? Are you saying external fixator and let the soft tissues cool off? You're fixing it, or are you just saying you're 89, you get a fusion and you walk right away?
Yeah, for me, I tend to be a fixer, especially in a lady like that, right? So she's a relatively healthy lady. She's up on a ladder, for crying out loud. And so I'm going to probably fix it, and I'll probably at least fix it partially while it's open, unless it's grossly contaminated. So that's something I've learned over time is generally that medial skin is never going to look better than it does the first time you take it to the operating room to do the debridement. So most of the time I'll at least fix the medial mal at the time of that initial debridement, and then close that skin once and be done with it. The lateral skin in that kind of pattern usually, at least in my experience, doesn't look all that bad. And so then I would fix the lateral side probably with a locking plate. Obviously, you don't even need to test the syndesmosis, like you said. Just put a couple syndesmosis screws across there, tight ropes, whatever your flavor of syndesmotic fixation is. But that's probably what I'd be doing.
So you do it all the day that she came in, depending on if it's nighttime or?
If it's me, then one of the nice things about where we are is I get to take care of my own messes, right? And so I know I'm going to treat this definitively in the long run, so I won't burn anybody by doing a partial job. So yeah, I'll at bare minimum fix the medial mal, and then everything else is based on what her lateral skin looks like, what time it is, how froggy I'm feeling, all that kind of stuff, right? So if her skin looks immaculate on the lateral side, and I don't think it's a problem, I'll just fix her then. If there's any question about the skin or time, I'll fix the medial side, close it, and then put her in an X fix and come back and do the lateral side later.
Yeah, I think that's great. I think the point about the medial skin and not wanting to go back through it is a really, really important one. So yeah, a very low threshold for at least a minimum fixing the medial side the night up. Dr. Weatherford, are you able to take your presentation out of presentation mode?
I am.
Thank you so much. Perfect. Yeah.
Yeah. Here. So just how about that?
That's great.
Yeah.
Thank you.
There you go.
Perfect.
Okay. Sorry about that. Good. I didn't have any notes for that one. All right. All right. So again, here we are. So we talked about this here. So just my thoughts on this, right? So she is 89, obviously she's healthy, 89-year-old, but she's an 89-year-old regardless. And so I do think you still have to consider the whole patient and kind of what's going to give you the least number of surgeries and the hope of the best outcome. But yeah, I mean, she had no antecedent symptoms. She's healthy. She doesn't have any peripheral neuropathy. She's not a diabetic. And so for me, I tend to be aggressive with the open ankle fractures as long as they're not grossly contaminated, and try to fix as much as I can the day or night of. And we have the advantage of having operating room availability. So if this came in at night, I would do it in the morning and do as much as I can in a single setting for an 89-year-old to give her the best chance of having a single surgery. So here we are going through the case itself. So for these, this is working through that medial wound. I would recommend I don't tee the transverse incision. I tend to just reflect it. If I can, I do worry about what that's going to do to the blood supply to the skin. I will provisionally reduce the medial malleolar fracture, which helps you to indirectly realign that comminuted fibular fracture. And then in this case, I used a locking plate. I think a lot of these don't have a great contour. They tend to put the fibula into valgus. So I will try to pre-bend them or compress them to the bone with this Verbruge. And then this is using a push-pull screw to regain fibular length. I have fluoro images of her other ankle. And have those saved for fibular length and rotation. If you look here, we're actually over distracting the joint a little bit, which is proof you can do that when you try to do this push-pull screws. You have to be pretty careful about that. Here's the final construct. So transsyndesmotic screws. You know, and we will go into the follow-up here a little bit, but looking at this in hindsight, even you can see that that medial malleolar fracture has already shifted. Even in my final fluoroscopic images, it's translated just a little bit laterally. And so I think that's something that portends negatively for this case.
So both of you guys showed medial mal screws as full 3/5 screws. Is that your default for all ankle fractures? Or you just do that for osteoporotic bone, or?
I personally am doing it for all of them because there's an opposite cortex and you should use it. If you flip that upside down and made it a tibial plateau fracture, you would get yelled at in fracture conference for putting a screw halfway across. So yeah, and honestly, the only difference is I think in these elderly or osteoporotic patients, I will reduce the fracture and place the screws positionally versus younger patients, I tend to place them in lag mode. But otherwise, yes, I'm purchasing the far cortex.
You do that for all yours?
No, not all of them. In all fairness, I did when I first got here. It's a little difficult from a teaching standpoint. Sometimes it's a big struggle to get that 3/5 screw across like that. And so I will use it selectively when I think I need it. The cannulated screws, I think are fine for certain applications. I'll tend to diverge my medial mal screws so I can still make them bicortical sometimes. But lengthwise, if I really think I need it for some extra structural integrity, the 3/5 solid screws come longer, at least in the vendor I use. So I tend to use those if I think I need them in situations like this to augment my fixation.
Cool. All right. Did you let her walk?
I did.
Right away?
So 2 weeks at 2 weeks post. Yeah. So yeah. And I mean, but I think again, it's a question, and this, as we will see in the follow-up, this is still a question. What do you want to do for an 89-year-old who won't be able to use their limb, right? I mean, they're healthy right now, but how much physiologic reserve do they really have? And do you want to take that away from them to achieve a good looking x-ray? Again, this is the conversation I think that's not clear. I mean, it's very clear for hip fractures, you need to do something to allow them to weight bear immediately. It's less clear because technically, at least, I think you can still mobilize better with an ankle fracture than you can with a hip fracture. But I still worry about taking a leg away from an 89-year-old. So I let them walk, you know, either right away or at most at 2 weeks. And if I'm doing something in a way that won't let them do that, then I really have to rethink what I'm doing.
Do you cast them? Do you put them in a walking boot, or?
So I put them in so I put them in a walking boot. I let them, you know, once I think that the incisions are healing appropriately, I let them do range of motion, which is typically pretty early. And I have some tips or techniques that I've developed over time with wound care that I think can help with that. And I have a slide on that. Oh, here it is. Okay. So yeah, I mean, this is something that I took from my senior partner when I started. He was foot and ankle. And so for another disclosure is that I did a trauma fellowship. I also did a foot and ankle fellowship. So I really kind of nerd out over these things. But this is honestly one of the biggest things that's changed my practice. I started to do this very early. He was using it for his total ankles, and he had a couple of publications that showed that it lowered the rate of wound healing complications for him with total ankle arthroplasty. So I started to use this on all my reconstructive foot and ankle surgeries, but also on my big traumatic foot and ankle injuries. So my calcaneal fractures, my pilons, and my 89-year-old open ankles. And so this is just an example of somebody with an extensile lateral calcaneal incision, 3 days post-surgery, still swollen, draining. And this is that same patient at 16 days post, you know, and usually at the 2 to 3 week mark, you're looking at these people, they're still swollen, they're still in pain, and this incision's healed. And that looks like a normal foot with an extensile calcaneal approach. So this is my 2 cents of like, this does matter. I mean, whatever your protocol is, that's okay if it works. I think that this management is great and really it's actively managing edema instead of passively just watching it happen.
Do you just do it post-op, or do you do
I
this
do it
around frames and things like that?
I'm doing it pre-op as well. So for pilons and calcs, I'm doing that pre-op as well. And again, anecdotally, we've looked this up. I'm hoping to write it up, but I've anecdotally seen this. It's cutting down my time to their definitive treatment.
What is that material that they're wrapped in? Is that just bias or?
It's basically just a short stretch gauze. So it is, so the materials are stockinette, basically web roll, and then they use this short stretch bandage. This is lymphedema treatment. It's the same stuff they use to treat patients with chronic lymphedema. I mean, there's a brand that we use, but it's basically short stretch gauze. It's applied in a specific manner that is supposed to reduce lymphedema. We usually change the bandages every 2 to 3 days. And it's again, for me, it's really been something that's helped my practice.
Interesting.
Yeah.
Cool.
So-
There was a question, and I'll expand on it. Would you have changed your weight bearing plan if the patient had a higher BMI? And I would expand that to, are there ever times where you don't let them walk at 2 weeks?
The problem is that this is it's a very subjective thing, but for an elderly patient or a medically frail patient, I really worry about that. The BMI doesn't really factor in for me. And if it does factor in, then that's when I think about changing my approach. If I think that person can tolerate being non-weight bearing for a period of time and that's better for them overall, sure, then I will delay their weight bearing. I'll supplement the fixation with an external fixator, something different. But yeah, I mean, if I'm worried about their health overall, you should prioritize that over their ankle. So no.
Okay. Cool. So what happened with her?
Oh yeah. So it drifted into valgus. And you can see that it's just, yeah, sad. Exactly. Yeah. So, and again, I would say that there's probably some technical issues with this along with the injury pattern, but I think she was probably a little bit in valgus even when I left the operating room. And, you know, so there's some retrospective kind of soul searching on this. So she was actually doing still pretty well at this point. I told her, I don't like the way your x-rays look, but you're going around okay. So keep doing what you're doing. And then here she is at 6 weeks. And then she wasn't doing as well at this point. So she had an increase in pain. She broke her fibula at the upper part of that plate there. And obviously syndesmotic reduction was lost. Talus has shifted and now the cat's out of the bag. So obviously in hindsight, I do wonder if this person would have been better served with doing an acute arthrodesis and hindfoot nail with immediate weight bearing. I still don't think that fixing her and delaying her weight bearing for 6 to 8 weeks is beneficial for an 89-year-old.
Yeah, it's the first.
Yeah,
Oh,
this is where we ended up. And I let her weight bear again 2 weeks after this.
okay. So there was a question earlier, actually, Tom, when you were presenting, we can answer it now. So it was, when you say hindfoot nail, you're doing a full fusion with the joint takedown.
So in this situation, obviously the soft tissues are much more appropriate. And yes, I did that. Even in situations where I think the soft tissues are comparable. So in other words, like if you have an acute open fracture or a whatever closed injury, but soft tissues are poor, host is poor, I still try to do some limited joint preparation. I just think I just don't understand the idea of shoving a red hot poker across the joint and then taking it out later or leaving it. I mean, I just think that if you can achieve some healing, it's better for the patient because at some point the implant will fail. It may not fail before the patient does, but I mean, if you can do some limited joint prep, I think it's still a good idea.
What about you, Tom?
Mine very much depends. My next case will show some of this. I think you have to do something. You can't just put the hindfoot nail in and let it ride. I think that'll fail eventually. Usually, unless the person passes before the nail does, right? And it'll either back out the distal screw or break the distal screws. It'll fail eventually. So mine is usually going to be based on soft tissue. I'll show the way I fuse around a hindfoot nail in my next case, but it's a big, relatively sizable lateral approach, osteotomy and fully preparing subtalar and tibia-talar joints. So I'm usually doing a hindfoot nail and then letting them walk at usually 2 weeks once the incision on the bottom of their foot is healed. but then staging and coming back and doing a formal fusion. I think there's something to be said for doing it and then maybe just removing the nail. I've never personally done that. Down the road after the fracture's healed, remove the nail. But if you had a relatively simple fracture and a real sick host, I think you could potentially try to remove the nail down the road too. But I think it'll fail on a long enough time frame no matter what.
How'd she do? Did she heal, Brian?
She did, yeah. So she's actually doing well. She's back living independently. She's still using a cane, but I mean, is not trimming her hedges anymore, but back living.
Yeah, interesting. All right,
Okay.
Tom, let's get to yours since you've got a nail in your next one too.
Yeah. Oh man, remember how to share.
As you pull it up, there was a question: is every screw in that plate locking?
None of them were.
Perfect.
Yes.
Okay. So now my next lady. So my first lady, I fixed, kept her off her ankle for 3 months, and she died in hemodialysis. Your first lady, you fixed and let her walk early, and she went on to a failure infusion. So now my logical thought process here is like, okay, well, let's just nail him right out of the gate, right? And so now I'm cheating a little bit. This is a 62-year-old female, but she's a pretty poor host. She had a ground level fall, roughly 2+ weeks ago. She walked it off for 5 days. And then went to an outside hospital where they told her she had a trimal ankle fracture dislocation, put her into a splint, and then she kind of walked that off for about another 10 days, and then showed up in our hospital. So a little over 2 weeks out, this is how she showed up. She is one of the worst alcoholics I've taken care of. Bad peripheral neuropathy secondary to that, and literally was one of the greatest substance use questions. I asked her, how much do you drink? And she said, as much as I can find. And I went, okay. And it was, she was socially very, very complicated, difficult patient. And I did not think she was going to follow any post-op restrictions of any kind. And this is what her skin looked like. I think it doesn't quite do it justice how it looked in the ER. She was actually a little more swollen than this once we got to the operating room. And I thought she was appropriate for a frame in the early part of her treatment. Placed her into an X-Fix, got a decent reduction of it. Here's our CT scan, but now I'm looking at a sizable posterior malleus that's displaced, obviously some subluxation of her fibula out of her incisura, a little posterior medial fragment. So now I'm looking at from some significant posterior work I'm going to have to do in a who is likely going to be a non-compliant patient. And so the thought process here was give her an internal X-Fix, right? So place a hindfoot nail without preparing the joint because I was worried about her soft tissues. Place the nail, restore her alignment, and put her into a splint in the early portion of the treatment. Let her walk it 2 weeks. Now, for me, if she is completely non-compliant and walks out of the hospital, okay, this construct should be able to take that for a period of time. I usually wait until the incision's healed on the bottom of the foot, but that's kind of where we're at. Now, she was a more recent case, but this is usually where I take these. This was a little different problem. This was an open pilon with some significant bone loss that I did. This is a second stage of a emasculate for, but similar idea. Do a hindfoot nail, I'll make a lateral approach. I will bisect the fibula, split it kind of in an anterior and a posterior half, leave the posterior half attached to its soft tissues, mill up the anterior half and use it as bone graft. Lay the posterior half down. I'll prepare the lateral side of the tibia and the talus, kind of chew up the lateral cortex of the tibia and take the cartilage off, prepare the lateral side of the talus and put lag screws. And so I have basically an autograft strut on that lateral side, and then lay the bone graft wherever I have a bony defect or into the joints as I compress them. So this is what she'll be getting eventually. Like I said, a long enough time frame, unless she's so sick that I don't think she's gonna to survive the year, then this is what the plan will be long term.
Can I ask you that X-ray you have with the acutely with the ankle fracture dislocation with the hindfoot nail? sometimes it's hard to get the alignment right? When you've got such a sloppy, dislocated ankle, what are your tricks? Because depending on your nail, and we won't use implant specific, some of them have more bends than others. Like, how do you keep yourself from getting kicked into a ton of valgus when you put the hind foot nail up?
I don't use nails with bends in them. So
Okay.
that's been my experience in my hands. It makes more sense based on the anatomy of the hind foot to have a little bend in it. But it is really hard for me to put that wire in the correct place and then not induce deformity with the nail. So just about any hindfoot nail I put in with a bend, I've induced some level of varus or valgus at the tibia-talar joint. So that's why I specifically try to use straight nails for this, because it's just way easier to maintain the alignment. I don't have as much trouble doing that for an ankle fracture as I do for like a pilon. If you have a length unstable distal tibia, it is futzy. To get this hindfoot nail up in the appropriate position, maintain length. I've got a bunch of different ways I've screwed that up and had to figure that out in the middle of the case. But for this, she was relatively stable and it wasn't all that bad. But I have struggled using nails with bends in them. I don't know if anybody else has had the same experience.
Do you use straight nails, Brian?
No, I use one that does have a little bit of valgus bend. I agree though, it's easy to put them into valgus because it will align to the diaphyseal tibia, and if your starting point's too lateral, the foot's going to swing into that. I mean, the things that I've done that have worked for me in some limited regard is I will place multiple wires pinning the foot. So basically I'll get my starting point with what I think is the correct position, which clearly isn't as well defined as, like, let's say a trochanteric entry portal. Maybe not a bad study actually. But then I'll place multiple wires retrograde through the foot to secure it, so it's less likely to shift as I'm placing the nail. And if I need to, I'll even place a blocking wire in the metaphyseal distal tibia, because I think that's one of the areas where your trajectory really goes awry. So those are the things, but I've still done the same thing. And that's also my argument against acute fusion, is that it's not easier, it's harder, right? Because you have to maintain alignment, hopefully prepare the joint, and then secure it in a stable manner.
It's a lot of moving pieces. All right, Tom, before you go on, there was just one question. It's a little off topic, but they're asking about X-Fix usage in your practice. Are you always using traditional Delta style frames, or do you guys ever use thin wire circular frames for these fractures?
I'm a circular frame hater. I believe they work. I've seen people do amazing things with them, but I can't wrap my brain around it. I just don't do them. I don't care for them. But I think it would be potentially a reasonable option if you're going to allow someone to weight bear potentially, right? But that's the whole goal here for me, would be to put something in that I could let you walk on, right? I'm looking at somebody that I want to make mobile, and whatever idea I have that I think I can do that with seems like a good idea to me. But no, generally for me, it's a standard Delta frame. If I'm really, I'll try to make sure they're dorsiflexed in neutral, at least in neutral in that Delta frame when I tighten it. And if I'm concerned at all, or if I think it's going to be a longer term frame, I will use a midfoot pin just to hold their foot up so they don't develop an equinus contracture in the frame. But it's a Delta frame for me, and I'll pull that off at 6 weeks in office usually.
Brian, you use any circular frames for this?
Not routine, not for acute fractures. No.
Yeah.
I mean, I just think that it's again, it's challenging. I think that you're getting a different set of problems, not a better set of problems.
Yeah, agreed. How'd she do, Tom? Did she heal?
She left the hospital, and as far as I know, is not returned. So she's doing great somewhere. That's it. So she was, in fairness, I think she's almost to 6 weeks. So this is a relatively fresh one. It's not, she hasn't gone quite far enough. I'll tell you next year at the Fix or Fuse.
Perfect. We'll come back.
Yeah.
All right, Brian, I think we have time for one more. You want to do your other one?
Yes, please.
Uh-huh.
Okay. Tom, you got to stop sharing though.
Oh, God. Yeah. Again.
Hogging the screen.
Wait, why you pull that up? They said, why do you split the lateral malleolus and only use the anterior part?
So I do that too, and that's not my technique. I was taught that. I can maintain soft tissue connections in the back. So it ends up essentially being like a vascularized fibula graft, right? So it ends up being a nice big strut that I can put a lag screw through, and it is living bone that I can compress both proximally and distally. And so
I got you. So you grind up the anterior bone, leave
Yes.
the posterior bone on a soft tissue attachment, and then just kind of
Yep,
close
and
the
then
door
just
behind
close
you.
the door. Yep,
Cool.
close the door after I've roughed up the bed that it's gonna lay in. I just lay it down and put 2 lag screws, one above tibia talar joint and one below. And it's worked well anytime I've done it. But yeah, that's why.
Cool.
Yeah, I do the same thing. It's awesome. All right,
Well, then it must work if you both did.
that's it.
100%.
Case closed. All right. Second case is a 67-year-old, but yeah, again, it's kind of similar theme here, right? So 67, but physiologically older than that, diabetic with neuropathy. But to be fair, the neuropathy also could be from their alcohol abuse. They're morbidly obese and have kind of these chronic venous stasis changes to their legs, so like leathery skin around their legs. And they were hit by a car while under the influence. So this is their injury. And so, it's kind of a transitional, right? It's kind of a pilonish ankle, or posterior pilon, if you will. And so I don't have pictures of the soft tissues, but decent amount of swelling. The obesity is somewhat protective in this situation, that they're not open or anything. And so you can see it's really, again, kind of creeping up towards a pilon, no major areas of impaction, but a pretty large posterior articular segment that's a posterior lateral and a posterior medial piece. And so for me, this is, again, this was a few years ago. I went a different route with this one. I think a lot of different options. I don't think their skin will tolerate what I think they need mechanically, which is to go from a posterior approach with an anti-glider buttress construct for this. Again, I still have a hard time with acute fusion in patients like this. So this is one of the tricks that I love to use for sagittal plane instability, for ankle fractures with large posterior malleolus components. And so, and I think that if you're going to do external fixtures on these, I love this technique. So I put my delta frame together. I put a pin in the midfoot like a gentleman, and then I use so I use a bump to translate the foot forward, but you'll still see they're going to follow that posterior malleolar fragment. And the problem is that the trajectory of your delta frame is from anterior to posterior. It's from the anterior tibia to the posterior calcaneus. And so every time you try to pull a length, you're going to pull that talus right out the back of the ankle. And so what I'll do then is I'll have an independent pin and use a clamp and basically use that to translate the tibia back over the talus, and then secure that clamp. And that has worked really nicely for me.
Say that again. Where is your independent pin?
So I'll put a single pin in the tibia proximally. I'll have medial and lateral bars go into the calcaneus off of that. I'll get my coronal plane reduction, AP reduction.
Oh, so you've already got carbon fiber, you've got rods connecting that tibial pin to your calc, so you've got your length.
I've got my length and I've got my coronal plane alignment.
Gotcha.
And then I'll place a second pin in the tibia. And then
Gotcha.
I'll put a transverse bar, right, across my medial and lateral bars. I'll secure that to my frame, put a clamp loosely on the distal pin, put a separate clamp tightened to the distal pin, and then use my bar and a lamina spreader to push the tibia back.
Huh.
Yeah, so I'm pushing on the clamp on the pin and then pushing against the bar to push the tibia back over the talus.
Do you over distract it with the first move so that you don't grind the heck out of the cartilage when you drive that tibia back?
I mean, for these, again, the hard part is we're talking about rotational fractures versus axially unstable, and this is a little bit of both, but it's usually more translation and rotation. So it doesn't take a lot to get the coronal plane reduction, and then you're just pulling them forward or pushing the tibia back over the talus. So yeah, I mean, yes, I guess the short answer is yes, I'll over distract a little bit, but it doesn't take as much as you would think.
You are a gentleman.
Thank you. I like 2 points of fixation above and below. It's just something I learned. So, all right.
It says that going back to that last X-ray,
Yeah.
I'm going to hijack for you for a second.
Yeah.
This one, I think, going back to your original question, Jen, this would be a difficult hindfoot nail. I think
Yeah.
you would
sure.
try to put that wire up. That wire goes right to where that fracture comes through. And I've done these before where if you don't control that posterior mouthpiece, every time you go to put a reamer up or go to put the nail up, it just widens. And then you got to be prepared to deal with that. So just showing up and going, I'm going to put a hindfoot nail in this. This is one that would make me worried with that. You have to address that reduction, or you have to accept the fact that you're going to be really wide at your mortise when you're done.
Yeah,
Agreed.
that's a great point.
So I because this guy's skin was never going to be okay, no matter how much lymphedema treatment or whatever he did, because he came in with it. So I used limited incision. I made one incision immediately on this guy and did the rest percutaneously. So to address that posterior, it's a fluoroscopic reduction. This is a bone hook in this situation to help reduce it. You can also, obviously, a clamp works really nicely here, but something to hold it. And then these are A to P lag screws. I did try to capture that kind of more medial to posterior medial separate fragment with this quarter tubular plate, and then just percutaneous fixation for that fibular fracture with an intramedullary screw. And then that external fixator stayed in place for this guy for 6 weeks.
Do you always use a 3-5 screw for your intramedullary fibular screws?
I do. I think that that's what I do. I think that it was perfectly reasonable, depending on some patients you can't get a 3-5 screw in, and some patients this screw is swimming in there. So there should be some modularity to it. This is what I do, because you still get kind of a 3-point bend when it goes up the canal. But yeah, I think there's nothing wrong with using a 4 or 5 screw or whatever, even 5-5 screw, depending on the patient.
Yeah, that's cool.
Yeah.
That looks
So-
great. So then you kept the X-Fix on for 6 weeks, and then
Yeah, 6 weeks, and then took it off, put him in a boot, and I think let him weight bear at 8 weeks, if I recall.
okay. All right. Let's see. All right, so there's lots of questions on the fibular screw. Asking for comments on fibular nails and thoughts on fibular nail or fibular screw in less than 5 minutes. But that's a good point, right? There's some on the market now, right? And
Yeah,
they're
sure.
sexy and they serve a good purpose. So
I don't know if we know what the role is yet. I mean, what I worry about with the fibular, although obviously in this situation it probably would be a very good option. I think what we don't know is for healthy patients, for people with standard ankle fractures, what the role is, and especially in length unstable fibular patterns, and most of them are, right? I mean, most of them are oblique or comminuted. There's not a lot of transverse fibular fractures that would be amenable to a nail. So I just don't know how well, because we really need the fibula to be close to anatomically reduced for the ankle to function properly. So even though it's not an articular fracture in and of itself, it's like a forearm fracture where it needs to be right for the ankle joint to function properly. So I don't know if by using a relative stability construct, no matter what it is, in that situation, that's my 2 cents. Although it seems cool.
Tom,
I'm always trying to plan the next surgery, right? If something goes wrong, some of the proximal locking mechanisms in the fibular nails, again, avoiding manufacturer names or anything like that, make me nervous. I'm not going to put something in that I'm afraid that I'm not going to be able to get out, or that may impede my next surgery. So that's part of my problem. And I haven't ran into a whole lot of fractures where I think I need a fibular nail over something like this, right? Most of the time it's I can get by and make it work with a screw. Yeah, I haven't found the fracture that I've wanted to nail yet. I'm sure it'll happen. I think pilons would be a reasonable time, especially if I'm doing lateral approaches and I don't want to make a separate large incision to fix a fibula.
mm-hmm.
All right, that I'll eventually find one that I think it's the right answer for, but I think the perc screw is relatively simple to do. And and I'm using it to usually augments my main fixation somewhere else.
Yeah. I mean, I think it goes back, I mean, I think it just goes back to basic principles, right? So, I mean, what are you trying to achieve? I mean, if you're trying to achieve relative stability, length and alignment, I mean, then sure, that nail's appropriate. But if you're trying to achieve an anatomic reduction to stabilize a periarticular injury, you know, I'm not going to start nailing my, well, no, I'm not going to take that back, whatever. I mean, like, I wonder if it's the right choice.
Yeah, so someone mentioned using a rush rod instead of a screw. I've seen
Sure.
that. I've seen bolted guide wires. You know,
Yeah.
there's a lot of things out there that people use. You know, all with varying levels of success. So yeah, no, it's an interesting. I mean, I think a lot of good questions and good research topics came up tonight, right? You know, we kind of keep coming back to this, like, think of the patient, get them walking, and that sort of thing. So we're inadvertently equating it to the hip fracture. We know with some of the acetabular literature that doesn't always pan out, you know, so it really would be a question, you know, and it's something that I think of too, you know, if I think about making someone immobile for 6 to 8 weeks and they're over age 80, that makes me very, very nervous too. It would be interesting to see if that actually is legit, right? If taking the risk of them falling apart and then needing a second surgery is worth getting them walking in 2 weeks instead of 6. It'd be a hard study to do, but I think it'd be a really interesting one.
Yeah.
Awesome. Okay, I think we have 2 minutes left. So we are gonna finish up with questions and cases. And would you stop sharing for 1 second? I just have to show the final slides. Thank you guys. Thank you everybody that participated and asked questions. As a reminder, these are the upcoming webinars. So the next one is going to be periprosthetic hip and femur fracture, which is very, very topical as well. And then infection, and then the distal femur nail plates that people love to talk about, the nail plate combo now. So some really good upcoming webinars as well. So thank you guys very much. Thank you to everyone who joined us. And everybody have a fantastic rest of your night.